Health Products for You and Shop Ostomy Supplies webinar. We're, of course, lucky enough to have Christine Kijek with us. And Christine is going to share a wonderful presentation tonight and provide information about ostomies and IBD. We apologize for the technical difficulties, trying to pull up the presentation now for her to start. So Christine, if you just give me a moment, you can speak a little bit if you'd like, and then I will try and find that the presentation.
Sure. So tonight we're going to talk about ostomies and inflammatory bowel disease, cut it short to IBD. Inflammatory bowel disease includes Crohn's disease and ulcerative colitis. Both of these conditions can result in either a temporary ostomy or sometimes a permanent one. IBD can cause systemic symptoms, whether you have a stoma or not. But tonight we're going to talk about those who have IBD and have an ostomy. You do need to be really diligent in monitoring your stoma and the skin around your stoma. It needs to be assessed for changes every time you change your pouching system. So most of what I see while doing ostomy care is skin issues related to Crohn's disease. We see a lot more stomas related to Crohn's. So the first one is peristomal skin breakdown. And if you're struggling with a good fit or a seal of the pouching system, that acidic stool output, if it's leaking, will really cause a chemical burn on that skin. Okay, the next slide.
Hold on, let me go. This is the first one.
Yeah.
This is the next one.
No, go to the next.
Okay, sure.
Okay, so so with that skin breakdown and the acidic stool, you really get this chemical burn. So we really have to make sure we're getting it in a good place. I'm sorry, can you go back one?
Sure. Let me see here. Make sure I can get to it. I'm sorry.
Oh, that's all right. We'll stay right on this one.
This one or the one before?
Yeah, so this is fine. This is the wrong slide too, because they got out of order. So go ahead and just go to the one that says fistula, Heather. I'm sorry.
Okay. Let me just see if I can. That one.
Okay, perfect. So we'll start with fistula formation. So Crohn's disease often will create fistulous tracts. And what the fistula does is it starts as a small bump, almost like a pimple. And it becomes very red and very tender. And these small bumps or lumps will break open and drain. And you can see the picture here. It's red, it's usually very tender, and these openings will drain some fluid. Now, this will actually create a problem with the adherence of the wafer because of that moisture underneath. So oftentimes it's treated with some antibiotics. The fistula tracts close, and then every now and again they'll build and fill with fluid and break open again. And so this is an on again, off again kind of problem. And it usually occurs because your Crohn's disease is not managed well. So, if you're not on a biologic, you might want to talk to your doctor about starting a biologic if this keeps occurring. All right, let's go to the next slide.
Sorry, let me just see if I can. That?
Yep.
Okay.
So Hydrodenitis suppurativa, otherwise known as HD, because it's easier to say. It's an inflammatory condition that affects the hair follicles. And we see it in a lot of places, not just peristomal skin, but it's found in moist areas like the armpits, the groin, sometimes under the breast, we'll see it as well. But for Crohn's, we see it oftentimes around the peristomal area. It's an inflammatory condition. The sweat and keratin, along with bacteria, builds up in the hair follicles, and it creates an abscess. And again, because they're tender and abscesses break open, these will occur periodically, and they really do need to be treated. So oftentimes they're with antibiotics, but people who have hydrodenitis, who don't have Crohn's yet, they're 3 times more likely to develop Crohn's, which is interesting because they're both autoimmune in nature. Next slide. Okay, so Pioderma Gangrenosum. And this is, we don't see it very often, but it does happen. They're ulcerations that are usually around that peristomal skin. They develop very quickly, and they will keep enlarging if they're not treated. So again, this is going to cause some problem with your wafer or your barrier from sticking well to your skin. Common in UC as well as Crohn's, but we also see this in patients with rheumatoid arthritis or have psoriatic arthritis, and they can develop Pioderma Gangrenosum even without having a stoma. They will cause scarring, these ulcerations. So what you want to do to avoid this is avoid injury to the skin. So when you're removing your barrier, do it gently. We don't want to be ripping or tearing or breaking the skin. It's usually diagnosed once this ulcer forms. It's diagnosed by biopsy. So I've seen ulcers that look like this, but they're really people with peristomal hernias would develop an ulcer that looks quite similar. And that occurs because of friction of the barrier on the skin and the intestine underneath. So the peristomal hernia will bulge open or bulge out. And so that just creates friction and it wears away the skin. And again, they do look similar. So we biopsy to get that definitive diagnosis. To treat these Pioderma Gangrenosum ulcers, they're usually treated with antibiotics, anti-inflammatory agents, biologics, and sometimes we apply dressings on them underneath the wafer. All right, next slide, Heather. Again, this is some more pictures of Pioderma Gangrenosum. Next slide. So stoma retraction. So oftentimes the stoma will retract down below the skin level. And when that happens, obviously it creates a difficulty with getting your pouch fit well and preventing leakage. The stoma will retract early on from, close to your surgery date, not too far out. And the skin can close over the actual stoma. So we do have to be really careful with this. A lot of people that have this stoma retraction in the early part of their recovery period will require a revision to open that up. Things that cause this retraction, it really depends on the reason why you've had your ostomy surgery. Sometimes if there's adhesions, the doctor cannot, or the surgeon cannot pull that stoma up really high. So it kind of gets stuck and scarred in, so they're not able to pull it up too well. What we do for pouching of these is we do use convexity. We do use some moldable rings or paste. Oftentimes we do belts. And Coloplast has this new protective barrier or protective seal, which is working well for this type of product as well. Next slide. So a stoma prolapse. If you've never seen one, here's a nice picture of one. Prolapses in and of themselves don't necessarily hurt. They don't cause pain. but that stoma can be stuck out that far because of swelling. So you do have to usually modify how you're cutting your wafer to accommodate a larger diameter. If it starts to become painful and swollen, you can manually reduce these by trying to push them back in. Oftentimes in the office, what we'll do is apply table sugar to it. That leaches out some of the fluid, and it makes it the swelling go down, so that we're able to reduce it and push it back in. If it is causing pain and it keeps recurring, then it usually requires a surgical intervention where they can remove that redundant part of that stoma that keeps coming out. Will it happen again? Not usually, but again, these prolapses can occur, so they do require surgery if they're problematic. Next slide. All right, so here is a stricture of, the first one is a stricture of at the skin level. So retraction of that stoma, it's below the skin level, and the skin is closing over it. So you have difficulty getting stool out of that, and that definitely requires a surgical intervention. The other picture is a stricture at the opening of the stoma. So when you have active Crohn's or active inflammation, that chronic inflammation will cause that scarring, and so the opening becomes very narrow, and that can really back you up, and you have less stool output. You may have some pain with that. That means we need to make sure your Crohn's, or if you have a colostomy and you have UC, that you're managed on anti-inflammatories, your biologics, so that we can get that inflammation down. If the inflammation is prominent and scarred because of chronic inflammation, again, a stoma revision is going to be important to have. Although I will say during colonoscopy, they do dilate those openings. If it's strictured to a certain extent, they're able to stretch that opening a little bit. And they use these Hagar dilators during that, and you're sedated, so you don't feel any pain for that. Next slide. Okay, so here is a picture of a Crohn's patient who has Peristomal Crohns on the skin. So it's not necessarily affecting the stoma itself, but it's that inflammation and inflammatory process on the skin. So this is just one of the skin manifestations that your Crohn's is not well controlled. Next slide. Okay, so other inflammatory conditions, the first picture is contact dermatitis. We see this if you have an allergy to maybe the barrier that you're using, or if you're using maybe a moldable ring or something that you've cleansed your skin with, you might see an allergic reaction that will look like this. And that's pretty indicative of that actual barrier. If you look at that circle on your wafer, it's in the exact spot that it will sit. The peristomal fungal infection, it's red, it's usually itchy. It presents as almost like a rash. You start to see little dots on there, and that's caused by moisture in the area. So an antifungal powder is usually what we use, and we cover that antifungal powder with a skin barrier, an alcohol-free one, so that it doesn't burn. Next slide. Okay, so this is a stoma from a patient with adenocarcinoma of the rectum, and it has now presented to affect the skin, just like the Crohn's cutaneous manifestation. We've got cancer that is now eroding through the skin, and again, that can be very painful. Usually, what we do in this instance is we would incorporate that opening into your wafer. So it wouldn't be, you wouldn't cut it round, you would cut it to include that piece of carcinoma. Other than that, I mean, most people who this occurs with are already under treatment with chemotherapy at that point. Next slide. All right, we don't have a picture here. It was earlier in the slide presentation of psoriasis. Heather, are you able to go back to slide, I think it's 3.
I think I'm going ahead now. Hold on.
One more. Oh, another one. One more. Here you go. Nope.
Okay, this one?
Yep, that's the one. So
Okay.
if you look at this picture, you can see the dry, scaly, almost silvery color. And psoriasis is an inflammatory process of the skin. So this, in this particular picture, this psoriasis is not so much close to the stoma. I have seen patients that have it in the peristomal skin right up to the stoma. So this creates a challenge with getting your pouch to adhere. So it's red, it's raised, it has these inflamed lesions, it's dry, it's flaky, it's patients with this feel burning and itching. It may bleed at times, again, which can cause your pouch to leak. And how it's treated, usually we send patients to dermatology to treat this psoriasis. And if it's not in the peristomal area, as you can see, the upper portion of it is probably outside of the barrier. So that can be treated with topical creams. But if it's close to the stoma, we can't do that. And I've had a couple of patients with this problem. New Hope has a pouching system that works by non-adhesive. It's maintained and placed with a belt that you wear very snugly or snug, so that you can treat the psoriasis topically and then put your pouch on, and you don't have to worry about it adhering to your skin. It's kept in place by that tight belt. They also use, dermatology will use UV lights for treatment. And others who have it really a difficult time with it will be put on biologics and anti-inflammatory medications. Okay, so Heather, now we can go all the way forward again to changes in the peristomal skin.
Oh, back here. Itching.
A little bit back more. Oh, one more forward. Okay, so skin around the stoma. It should be healthy, just like the rest of the skin on your abdomen. It should be dry, no redness, no rashes, no breaks in it. Next slide. Reasons why these changes occur can be for any number of reasons: frequent pouch changes, flare of your Crohn's, poor fit, or an allergy to the barrier. So your signs of peristomal skin changes: if you have itching or pain around the stoma, if you have frequent leakage under the barrier, if you have bleeding from the stoma. Now, I will mention that the stoma itself, it's very vascular, so there's a lot of capillaries there. And when you clean it or wipe it or rub it, they break very easily. So you may see little dots of blood from time to time on your stoma, and that's okay, and that is normal. It's when your bag is filling with blood that you need to call the doctor. Next slide. So there could be bulging of the area around your stoma. Again, that's most likely a peristomal hernia. Changes in the skin color around the stoma. Sometimes it's red, sometimes it's pale, sometimes it might look whitish. It could be purple if you're starting to develop an ulceration, or that Pioderma Gangrenosum or ulcers can actually turn black and necrotic. So you got to watch for these changes. If you have any type of rash, we're going to look at fungal rash, folliculitis, so that's inflammation of the hair follicles. We also are going to be watching for any blisters or wart-like growths around the stoma. That can mean other things. And so you really want your stoma nurse or your surgeon to take a look at them if it's occurring. Next slide. Oh, I guess we got a little messed up. I got a little more to talk about.
Okay. Love you.
So here's some more tips to maintain that peristomal skin. So when you're cleaning, avoid soap, use just water. Many soaps will leave a residue on your skin and cause poor adhesion of your next pouching system. You want to be sure your wafer or barrier fits well. The size of your stoma can change during the whole first weeks, up to 6 weeks after surgery. But after that, changes can occur if you gain weight or lose weight, and that can change how your sizing is. So we have to watch for that as well. Change your pouch routinely. Set up a schedule. If you have a colostomy every 4 to 5 days, if you have an ileostomy every 2 to 3 days, so that you're always monitoring that skin on a regular basis. When you remove your pouch, you want to do it gently. We mentioned that earlier, so you don't want to tear the skin. And again, assess that skin with every pouch change. Now, patients with Crohn's disease often have had other bowel resection. So you may have some shorter small intestine. Sometimes you have less colon. So depending if you have a colostomy, that scarring or active inflammation can cause an obstruction. So if you have a stoma because of Crohn's, 9 times out of 10, you've had obstructive symptoms before, which you probably know about. But for those of you that have never been obstructed, you want to pay attention. So signs of obstruction will start with abdominal bloating and distension. Usually you start to get abdominal pain that's crampy or spasm-like in nature. You lose your appetite. You don't want to eat. You have no gas coming from your stoma or no stool output. And of course, you end up eventually having nausea and vomiting. So there are some things you can do if you think you're heading towards an obstruction. If you're noticing swelling of the stoma, and this is in ileostomy, you may have some extra edema all of a sudden occurring at your ileostomy. Try changing your pouching system. If something happened and it's a little too narrow, you could be blocking things from coming out. So I would start with that and open it, cut the opening a tad larger just to accommodate that. You want to back off your diet. You want to reduce to clear liquids. We do want you to remain hydrated, but we don't want you taking in solid food because that's just going to add to that obstructive process. You can try taking a warm shower or applying heat to your belly. Sometimes that will help relax the muscles. If you're really uncomfortable, but able to take a little bit of a walk, walking stimulates that peristalsis that pushes things through your intestinal tract. So walking can sometimes help that. You can even massage your abdomen near the stoma to help break up something that might be blocked a little bit. Now, if you start having nausea, vomiting, or severe pain, usually you're not eating or drinking, you're going to call your doctor. You're going to head to the emergency room. I would suggest you bring ostomy supplies with you because if you're admitted for a bowel obstruction, they might not have what kind of products you use for your ostomy, and you want to be comfortable and use your own products that you know work well for you. After surgery, I'm just going to talk a little bit about diet for those with IBD. So nutrition, very important for healing. And I know that sometimes there's some absorptive issues and maybe some malnutrition that occurs because you can't absorb certain things. Or you just have a poor appetite from the active Crohn's. We do need to make sure you're getting in enough calories. Your calories, your body is going to use to help fight that inflammation. And it's also for healing after surgery. Protein is so important for you to heal appropriately. Medications, we do want to make sure that if you need your medications such as Humira or Remicade, or some people are on Stelara or pill form anti-inflammatories or biologics, we want to get you back to your regular regimen as quickly as possible to keep those flares down. Sometimes some of the medications that we use to treat Crohn's can cause a reduction in your appetite and give you nausea. It can affect your sleep. And so we really want to stay on top of your diet. Immediately after surgery, typically we have you on a low fiber diet, no raw fruits or vegetables, no seeds, no nuts. I know many people with Crohn's don't eat those things anyway, but some people can. After surgery, once you have your stoma and you're 3 or 4 or 5 weeks out, you may now be able to tolerate those types of foods. And I would start in very small amounts, just because you want to see how it's going to affect you. So you don't want to do too much at once. Now, if you've had multiple bowel resections and or you have an ileostomy and the output is very watery, foods that naturally thicken the stool without adding fiber will be things like white rice, pasta, potato, anything in your breads category, cereal, Cheerios, things of that nature. If you're going to snack on pretzels, that helps to absorb some of that fluid in your GI tract. Tapioca will help thicken things, along with peanut butter. Peanut butter is a great source of protein post-operatively, and it will also help thicken. Your cheeses are good for that as well, protein and thicken. Marshmallows, those are a great trick. Now, I don't recommend marshmallows as an everyday thing to keep your output thick. Marshmallows will slow down ostomy output for a very short period of time. And they're great to use if you need to change your pouch in an emergency because it's leaking and it's very active. I suggest you eat 3 regular size marshmallows, wait about 5 minutes, and then go ahead and change your pouch. Of course, if you're diabetic, I don't recommend marshmallows. And so to close, IBD creates multiple challenges for ostomates. It's important that you stay aware of changes with your stoma and the peristomal skin to allow you to quickly seek treatment by a stoma nurse or your surgeon. Sometimes your GI physician can take care of some of these things as well. Timely evaluation and treatment will minimize your discomfort and get you back on track.
Well, Christine, this was such valuable, awesome information. I'm so sorry to our viewers that there was some sort of technology challenges, but the information nonetheless is fantastic. It's the point in the webinar now where we open up the opportunity to ask a question in the Q&A section of the Zoom. So if somebody has a question about the presentation, I'm happy to open the presentation again and answer any questions that you had on any of the slides or any other questions pertaining to this information that Christine talked about with ostomates and IBD. just give it a minute to ask.
Yeah, and I'm curious as to of the ostomates that are listening to the webinar, how many have Crohn's versus how many have UC?
Good question.
Yeah, yeah. I mean, obviously, there's other reasons people have stomas, but as far as inflammatory bowel disease goes,
I think it would be great if we were able to publish this somehow in our, through our channels. I mean, I know this is recorded, but these slides are super helpful, and perhaps we can revisit this, because this is a great topic, and certainly something that many ostomates deal with on a regular basis. So, and the cause, obviously, of a lot of their issues. So I think it's super valuable. I right now, I don't have any Q&A. I don't have any questions that are on the table.
okay. Well, and I'll look into, Heather, getting it posted on the HPFY website. So, so patients, if they're interested or want to look at those slides, they'll be able to click a link. I think we can do that. Yeah,
and certainly, if not that, then certainly through our channels, our YouTube channel, or maybe perhaps in an email newsletter or something to that degree, we can find out if there's a way that we can share these slides so that people have them as a reference. And then this, of course, is being recorded, so people will see it in the presentation.
Okay. Yeah, I think that's a good idea.
Okay. Okay, so if there's no questions, again, Christine, thank you so much. This information is tremendously valuable. Thank you for your time and sharing this information with our viewers. And again, our webinars are the fourth Thursday of every month. And we will be back next month with more information. Christine, I don't know if you have a talking point, or if it will, if we will post it down the road.
Yeah, I don't have a topic as of yet, so we should be posting that probably in the next week or so.
Okay, great. Okay, well, with that, we say, everybody, have a good evening.
Yes, thank you all. Take care.